Day of Expert event. And also welcome to all of you watching online. Thank you for being with us. So my name is Qiang Chang. I'm a professor of medical genetics and neurology and also the director of the Weisman Center. I'm here to give a quick introduction to you and to tell you, just in short, who we are, where we come from, what we do, and where we want to be at. So in one sentence, what we do here at the Weisman Center is to advance the knowledge in human development, developmental disabilities, and neurodegenerative disorders. So quickly, for those of you who are not familiar with the terms, I want to tell you what we mean by intellectual and developmental disabilities. And that is a term to describe a collection of conditions that have very early onset, either happens before birth or shortly after birth, and affect the individual for the rest of their lives, cause a lot of challenges in their lives. And examples of that include many of these conditions you are all familiar with: autism, Down syndrome, cerebral palsy, Rett syndrome, Fragile X, so on and so forth. In contrast to developmental disorders, degenerative disorders often happen later in life. So that's a later onset. And it has a degenerative component because there's cell or tissue loss in the brain. Of course, since the onset of the condition, it would affect the individual's lifespan, well, the rest of their life as well, and cause many challenges in their life, their family's life, and the community as well. Examples for that we include Alzheimer's disease, Parkinson's, ALS, and these are very common ones. And of course, the brain injury conditions would often lead to similar cellular and molecular deficits as those degenerative diseases. So those are the things we focus on, the conditions we focus on, and the approach we take, or the questions we want to answer include really these three major aspects. One is the cause. Once you know the cause of the conditions, you could start create models, and you should be able to better understand the mechanisms underlying those conditions. And we, of course, want to know more about the consequences of these on individuals and families, and we would hope in the end find a cure and treatment, effective treatment for those conditions to improve their quality of life and their families as well. So where we came from, we bear a name of Harry Weisman. Is a everything he did, we continue doing today. He was a physician who take care of families and patients, and he was a researcher, a cutting-edge leading research figure in the field to understand the cause, mechanisms underlying the disease, and trying to find a treatment for individuals affected by the condition. This is PKU he was focusing on. And also he did a lot of, in modern days, words, outreach. He's the one who advocated for testing in newborns to find individuals with the condition, because the early you provide intervention and treatment, the better outcome the individual will have for their lives. And that applies, that principle applies for many of the developmental disorders we study and try to intervene today. So it's a combination or integrated way to conduct research, provide service, and doing outreach. And this is a picture of the center when it was being built. Harry Weissman was on a presidential committee convened by President John F. Kennedy. That's the committee that generated the recommendations to create the Eunice River National Institute of Child Health and Human Development, and the network that studies these conditions called Intellectual and Developmental Disability Research Centers across the nation at the same time when an SCHD was established. So it's his work that led directly to the creation of not only this center, but a collection of centers across the nation today. There are 14 of them across the nation. We are one of the original ones. So we're strongly supported by federal government to study this area because there was not much done in the area in the 1960s, and that was certainly not acceptable to the president and the people who cared about this large community at the time. So that original building that Kennedy Research Laboratory established in 1963 was still here on campus. Many of you probably have walked by it. So from there, we started as an integrated research center. To today, we have more than 600 people coming to the center every day to collaborate, to do those noble work, to better understand the conditions and to find treatment and interventions for those people affected. And we have thousands of people coming through our clinics every year, and we have many research grads supporting all of those investigators here at the center. You can see that they're coming from a wide-ranging departments across the campus, 21 departments, well, 28 now, so we're growing. We're under the office of VCRG and one of the biggest multidisciplinary research center on this campus. So as I said, continuing Harry Weissman's tradition, we do research, we do service, and we do outreach, and we do training and education in this continuous building. And that's the nature of our activity, and that is what's making our center unique, because by generating a lot of collaborations across those spectrums of wide-ranging activities, we are more innovative, we're more effective in tackling those problems we are interested in solving. So in terms of research itself, it is really also wide-ranging and multidisciplinary. It goes from those stem cells in a dish all the way to human subject research, and you can see the brain imaging facility right here through the window. It's the MRI scanner to look at what's going on in the brains of the individuals affected by those conditions. And we even have a good manufacturing GMP facility that supports early clinical trials. So really a very impressive range of research activities, and we do training. We take that very seriously because that gives us the next generation of researchers and service providers to address these compelling issues. So to date, we have trained more than 10,000 undergraduate and graduate students and trainees since 1973. So it's a large number of trainees that we send out to the community to continue the impactful work. And we even have a preschool in the center that is also Harry Weissman's original idea, to not only care for the individuals affected by the condition, but also to provide education opportunities. and we continue that tradition today. 1/3 of the slots in the Weisman Early Childhood Program is reserved for children with special needs, and they receive on a daily basis occupational therapy and physical therapy interventions in the facility. At the same time, they're embedded with typically developing children, and it's all-inclusive education from early ages. And we have a large number of specialty clinics in this building. There's a strong focus on intellectual and developmental disability, including a Down syndrome clinic, one of the largest in the country, I believe. We also have intervention programs in the center. The autism treatment program is one example. It's an example of the impact of multidisciplinary research happening and innovative research happening at the center. So many of the intervention schemes are evidence-based, and some of those are came from really research happening in the center. And we have a large number of outreach activities in the center, and I mentioned this one because Harry Stevens is the first administrator of the center. It didn't carry the director title at that time, but we regard him as the first director of the Weisman Center. He started this international collection of arts created by individuals with intellectual and developmental disability. And last year, there was an exhibit at the Chazen Museum. I went there to look at it. It's a very impressive array of arts, and I was amazed by the ability of those individuals to create in my view, mind-boggling arts. Some of those things, one of the pieces of arts that I was very impressed by is very colorful creation by someone who has been blind at birth. So the person had no visual or vision from very beginning, but just through the touch and the feeling about temperature of these different colored articles, and this individual could create very complex and beautiful, colorful arts. So, so I think the other quite famous activity in the community is this children's theater. Happens in the winter. My children, certainly when they grew up, did enjoy those wonderful performances at the event. And we also have a grandparents network. These are older people who have family members and offsprings affected by intellectual and developmental disabilities, and they come together every month to have coffee, breakfast together, to talk about what matters to them, and then to hear about the innovative and cutting-edge research is going on at the center and what kind of services are available. So that's one of the ways we interface with the community we serve, and we view that as very essential to accomplish the mission of the center. And of course, it would be amiss to forget mentioning this series, the Day of Experts. We've been doing this for a number of years, and to cover these major conditions close and dear to the hearts of our community. And today we're here for Down syndrome, and we have a very impressive line of speakers today. I know that you will get a chance to hear the latest happening in the lab here at the center, and how that may impact your lives and your families. And we'll have, as always, a rich panel discussion on questions that you are interested in. So that's just a quick, 64-mile overview of the center. Hopefully you've had an idea of who we are, where we came from, and with your support, I believe we could really do great things for our community and make an impact. So thank you for being here again, and happy to answer any questions you may have. Thank you so much. So we have the next speaker.
So good morning. My name is Lindsay McCary. I'm the director of the Autism and Developmental Disabilities Clinic here and the psychologist within the Down Syndrome Clinic. And so today I'm going to talk a little bit about the co-occurrence of Down syndrome and autism spectrum disorder. We could spend most of the morning talking about the overlap of these two conditions, but this is really kind of a broad overview, and I'll be on the clinician panel later if there are additional questions. So briefly, I'll talk about Down syndrome, which all of you are familiar with, and autism spectrum disorder, what autism spectrum disorder might look like in an individual with Down syndrome, what are some of the risk factors and symptoms, and what does an evaluation for autism entail? So what would you expect if your child is receiving that evaluation? And briefly, some recommendations and resources. So all of you are familiar with Down syndrome, but it doesn't hurt to emphasize that Down syndrome is something that can be diagnosed with a specific test. So there's a yes or no answer based on that medical evaluation. Whereas autism spectrum disorder, although we can pretty reliably diagnose this condition, usually we're gathering multiple sources of data, behavioral data, to be able to evaluate whether or not somebody is diagnosed with that condition. In Down syndrome, we know the cause is the presence of a full or partial trisomy of chromosome 21. With autism spectrum disorder, there are many genes that have been implicated in the condition, and we know that there is a genetic component, but we don't understand one clear cause of autism spectrum disorder. In Down syndrome, oftentimes individuals have an intellectual disability that ranges from mild to moderate severity. With autism spectrum disorder, actually a minority of individuals with autism will also have an intellectual disability, and instead we define autism by differences in social communication and social interaction and the presence of some repetitive behaviors. It's important to note that individuals with Down syndrome also engage in repetitive behaviors, even if they don't have that co-occurring diagnosis of autism. So we'll talk more about what that might look like and when it might be appropriate to ask or seek out that evaluation. So I'm going to talk a little bit more about what autism is, because some of you may be less familiar with that condition. So to diagnose autism, we use the Diagnostic and Statistical Manual 5th edition. What that is a large resource book that has different neurodevelopmental and psychiatric conditions and defines the symptoms or the criteria that we're evaluating to say whether or not somebody has that condition. And so the DSM defines autism based on these 5 criteria. The first are deficits in social communication and social interaction. So what that means is not that somebody is not interested in social interaction, but how they engage in social interaction or the quality of those interactions might look a little bit different. So maybe they ask somebody to play with them by tugging on their shirt rather than looking at them or using vocalizations. Maybe that individual is less responsive to other people's emotions. Maybe they're not seeking out comfort when they're hurt or are sad about something. So it's how they're initiating interaction may look different. We also talk about restricted and repetitive patterns of behavior. And so what that can look like are things like hand flapping or doing things with one's body. It could be repetitively playing with a toy. It could be having difficulty with transitions or changes in routine. It could be having highly restricted interests, so really liking a specific topic and referencing that topic over and over again. And it can look like sensory differences. So either being over or under responsive to different sensory stimuli. With autism, we expect those symptoms to be present early in the developmental period. So we would not expect these symptoms to first emerge in adolescence or young adulthood. These are things that we're noticing prior to the age of 5 or 6. Often these symptoms are causing impairment in multiple environments. So it's not just somebody who's having some trouble with social interactions at school, but we would see impairment at school, at home, and in other settings. And what's most important when considering autism within the context of Down syndrome is that these symptoms or behavior are not better explained by an individual's intellectual disability or developmental delays. So any differences in social interaction are above and beyond what we might expect given developmental differences. And so we'll talk more about what that might look like. So I show this graphic because it highlights the complexity of autism spectrum disorder, and this is really referencing autism not within the context of Down syndrome, but the dark blue circles represent the core features of autism, and the gray circles represent all these symptoms that may occur with autism. And so similar to Down syndrome, it's a very complex condition, and individual symptoms are going to be variable. So with autism, sometimes there are sleep differences or gastrointestinal differences. There may be inattention or hyperactivity or mood and anxiety disorders. So all of these are factors that we have to consider when evaluating autism spectrum disorder. So just briefly, some information about autism, again, not in the context of Down syndrome. We know that autism occurs in about 1 in 59 children within the United States. It's more common in males than females. About 10% of individuals with an autism diagnosis will have a co-occurring genetic diagnosis. So Down syndrome, Fragile X syndrome, tuberous sclerosis are some examples of that. In children with autism without a co-occurring genetic condition, we can reliably diagnose the condition around 2 years of age, and that diagnosis has shown to be stable over time. That age of diagnosis gets a little bit trickier when we consider co-occurring genetic conditions. And there has been an increase in prevalence over the last few years in autism. So I will say, when we think about autism within Down syndrome, this is an area where there is not a substantial amount of research literature. There are several labs within the country who are starting to study the earliest emergence of symptoms of autism in individuals with Down syndrome, and they do that by studying really young infants and collecting physiological measures and behavioral measures to say, are there symptoms early in life that can help us understand who will develop autism and who will not. But what we do know from the research literature is that those with the dual diagnosis of Down syndrome and autism tend to have greater intellectual impairment. So those autism symptoms aren't solely explained by the greater intellectual impairment, but are shown to be above and beyond those developmental differences. So those individuals are having a harder time with the back and forth of social interaction. In individuals with the dual diagnosis, there are higher rates of stereotyped behavior. So what I mean by that are repetitive behaviors one does with their body, repetitive actions with objects, repetitive use of language. So this can be somebody who repeats the same thing over and over again or has repetitive vocalizations, or somebody who's repeating back what other people say in a non-functional way. So it's not very useful to get what they want. And overactivity or symptoms of ADHD can also be more common in this population. As I mentioned before, when we think about Down syndrome and autism spectrum disorder, we're really focusing on that social piece and what are differences in social interaction. So individuals with the dual diagnosis do have a harder time orienting to social interactions, so things like responding to their name or responding to really exciting things, like if a parent's like, hey, look at that, they might have a harder time with that. They're less often initiating social interactions with other people, so going up to other kids or asking for social interaction with caregivers, and they have less shared affect. So what we mean by that is if they're really upset or scared or really excited, they may be less likely to direct that to another person or to respond to another person's emotions in that way. But again, I emphasize that research is still somewhat limited in this area, and hopefully we'll be able to understand more about what autism looks like in people with Down syndrome as more research emerges. So similar to research on the behavioral phenotype, we have less information about what some of the risk factors might be, but we do know that infantile spasms or seizures early in life can be a risk factor, similar to individuals with autism without Down syndrome. Complications from heart surgery, early hypothyroidism, and being a boy are also risk factors. In autism spectrum disorder without a co-occurring genetic condition, we know that about a third of individuals experience a period of regression or loss of skills around the second birthday, and often that looks like losing some language skills or differences in how they're interacting socially. We do know that the same thing can happen in individuals with Down syndrome, but often there's a greater percentage of individuals with Down syndrome who show this period of regression, and the regression is shown to be later in life. So whereas in individuals with autism without Down syndrome, we might see that around the second birthday, and individuals with Down syndrome, we might see that closer to the fifth birthday. And this is really important because if we're monitoring early development, we may need to screen for symptoms of autism later in life. So for individuals without Down syndrome, we usually screen at 18 months and 2 years of age. For individuals with Down syndrome, we should continue to be screening for symptoms of autism so that we can catch individuals who may show these differences. So when to ask the question? I would say as a clinician that whenever you as a parent or caregiver are concerned that these behaviors may be present in your child, you should be asking the question because it never hurts to go through these evaluations to make sure or to better understand your child's strengths and weaknesses. For all of us as clinicians, we can sometimes attribute behaviors to what is known about an individual. So what that means is in individuals with Down syndrome, since we know some of these behaviors are part of Down syndrome, sometimes clinicians will say, well, the symptoms that are being described are because they have Down syndrome. And so we as clinicians always have to remember to look at all the possibilities and evaluate for other conditions as necessary. So oftentimes we're relying on the parents and caregivers to let us know when they've seen these patterns of behavior in other settings. And when we think about autism in Down syndrome, we're really focusing on the absence of certain behaviors rather than the presence of other behaviors. And what I mean by that is I, as a clinician, am less concerned about a child with Down syndrome who engages in hand flapping because we can see that in Down syndrome. I am more concerned about an individual with Down syndrome who's not initiating or responding to those social interactions. So that lack of social engagement versus the presence of repetitive behaviors. Both are important, but helpful to tease apart those symptoms. So what does an evaluation for autism entail? For individuals, all individuals, but especially those with genetic conditions, it's really important to have a good medical evaluation first to rule out any other medical conditions that may be causing or mimicking symptoms of autism. So in Down syndrome, we think of things like obstructive sleep apnea. That might lead to different behavioral changes that might look like autism, but understanding that or treating OSA can help us tease that apart. Ideally, an evaluation is with an interdisciplinary team. So we want a physician, a psychologist, speech pathologist, OT, social worker, kind of a variety of different professionals who are working together to best evaluate the strengths and weaknesses of the individual. Sometimes accessing an interdisciplinary team can be challenging, so if that's not available, I do want to talk about the components of an evaluation that are really important. It's very important to understand somebody's cognitive or developmental functioning because we are going to compare social skills to what their developmental level is. So what I mean by that is for an individual who's maybe 6 or 7 years of age, but developmentally is functioning more around that 3 or 4 year level, we want to compare their social development to that 3 or 4 age equivalent, not to the 6 or 7 age equivalent. So having a good assessment and understanding where that developmental level is very important. We want to be able to understand adaptive skills or daily living skills. So how is an individual functioning within their environment? What are their language abilities? And with language, we're thinking about how they use language, how they understand language, and the social components of language, or the pragmatics. And when evaluating for autism spectrum disorder, we want to be using standardized tools. And so some of you may be familiar with the ADOS, or the Autism Diagnostic Observation Schedule. ADIR and CARS are some other tools, but they're really useful tools that have been validated to really get a good sense of symptoms of autism. And as I mentioned briefly before, we want to consider somebody's developmental trajectory or developmental course as we tease apart other explanations for behavior. So in an adolescent who all of a sudden is showing symptoms of withdrawal or is not being as socially engaged as they were in the past, autism may not be the best explanation for those behaviors because they represent a change from that individual's kind of baseline. So in those cases, we might consider other explanations for behavior, such as things like anxiety or mood disorders, other underlying medical conditions. So we really want to have a good sense of kind of this individual's baseline or typical functioning. So some families will ask, why does it matter? My child has a diagnosis of Down syndrome, and from that they're able to access intervention services and school services. So what does this additional diagnosis provide, or how is it useful? I would say that most developmental issues likely are similar, but the targets of our intervention might look different for individuals with this dual diagnosis. So with autism, since we know one of the core features is social functioning or social interaction, we may target some of our interventions to address those skill deficits or skill weaknesses. So maybe the focus of speech therapy or IEP services shifts a little bit to have more focus on that social piece. There may be additional medical workup that's recommended within this context, and there may be increased social support available. I can't emphasize enough that it is helpful to connect with other families who also have a child with a dual diagnosis and to be able to share in that experience. So what's next after receiving a diagnosis of autism? Again, the need for family support is really important, and there are some great resources out there that I'll share with you for connecting with other families or people who have experienced this dual diagnosis. Specific to the diagnosis of autism, some families will choose to initiate ABA therapy or applied behavior analysis, which is considered the gold standard treatment for symptoms of autism. And so what that can look like depends on a child's age and the other services that they're engaged with. But typically for very young children who are not yet in school, ABA therapy can be a very intensive model, somewhere between 25 to 40 hours a week of one-on-one intervention with a therapist to help address some of these social skills and repetitive behaviors. As children enter school age, the therapy becomes less intensive because they're in school and have other activities, and so it might look like 10 to 15 hours of individual therapy. It's important to communicate findings with your child's school team and other professionals who are working with them, again, because the goals of treatment may be shifted based on this new diagnosis, and of course, communicating with your child's pediatrician or primary care doctor. So I do want to share some really useful resources that are available both for individuals with Down syndrome and autism, but also just individuals with Down syndrome alone. So the first resource is called When Down Syndrome and Autism Intersect, a guide to Down syndrome autism for parents and professionals. And this is a really helpful resource for families and professionals to better understand this dual diagnosis and the co-occurrence. The book is written by a family member and a medical professional, so there are some nice family stories and some resources around things like dental care, IEPs, and other intervention services. So this is a really nice resource that's available. The second resource is Supporting Positive Behavior in Children and Teens with Down Syndrome. And this book is written in general for individuals with Down syndrome and how to support more positive behavior. How do we intervene on some of the more challenging aspects of behavior? And then finally, the Wisconsin Regional Centers for Children and Youth with Special Healthcare Needs is a great first step. So if you're considering whether or not an evaluation is appropriate for your child, the regional centers can help direct you to resources within your community, as well as if you're seeking additional treatment resources or family support groups. This is a resource available to people throughout Wisconsin. I included the information for the Wasteman Center clinics, and I do know that there is a family group sponsored by Mads and Gigi's Playhouse for individuals with the dual diagnosis. And additionally, there are some online resources that are specific to autism, but they're free and available for individuals who are interested in learning more about intervention resources or how to implement some of these strategies within your daily routines. All right, so are there questions? Mm-hmm.
My name is Nancy Aylar, and I'm currently the president of the Madison Autism, the Autism Society of South Central Wisconsin. And one of the things that's always puzzled people in the autism community about the DSM-5 is the complete lack of coverage of the sensory issues surrounding autism. Mm-hmm. And could you address that? Because I noticed that you also, in your slides, do not talk about that. And that's something that autistic adults talk about all the time. Mm-hmm. And I think it's a significant thing for anyone working with someone with dual diagnosis. Mm-hmm.
Great. So the question was about the sensory aspects that commonly occur in individuals with autism and whether or not that's addressed within the DSM. So the previous edition of the DSM-4, did not address sensory needs of individuals with autism as part of the core symptoms. But in 2013, the newest edition of the DSM was released, and sensory needs are part of the core symptoms. They fall under the category of restricted and repetitive behaviors. And so an individual who has high sensory needs or sensory aversions, that is part of the diagnostic criteria. Yeah.
And could you just briefly address what that might look like for someone with Down syndrome and trying to, think about that? Mm-hmm.
So kind of what would that look like for somebody with Down syndrome? And it can present in a variety of different ways. So for some individuals, they really do not like certain sensory input. So it could be a difference with tolerating food textures or clothing textures, having difficulty with public toilet flushings, things like that. Or it could be somebody who really seeks out that sensory input. So for some individuals, they might enjoy heavy work, so maybe pushing furniture around, or they like to create a lot of noises with toys because they're really seeking some of that sensory input. So, and some individuals can have sensory aversions and sensory seeking behavior together. Other questions?
Can you go back 2 slides just for a minute?
Yes. And I think these will be available on the website as well. Yes.
Could you talk more about the incidence? Your statistic was a lot higher than what we typically hear.
Yes. Yes, so you're right, I did not touch on that. So the range of prevalence of the occurrence of autism within Down syndrome is somewhere between 5 and 39%. And the reason there is such a range is because there haven't been a ton of studies really thoroughly evaluating the prevalence. And so the range is based on the study sample and how a study chooses to diagnose autism and what tools they use. So it is a broad range because we don't have as much literature to kind of narrow that down. Some people will use the estimate of around 10% of individuals with Down syndrome will have this co-occurrence. So it is something we're still trying to learn more about, of exactly what percentage of individuals will have this dual diagnosis. Mm-hmm.
You had a couple slides of information on intellectual development and IQ.
Yes.
And oftentimes there is a stigma regarding that intellectual development and IQ. Are you saying there that basically a person who has a dual diagnosis or even a single diagnosis, that their intellectual capacity would be general to anybody else in society, that we all have various IQs, or what do you mean by that?
I'll try. I think I understand your question. So we do all have a variety of abilities when it comes to intellectual functioning. And for most of us, when we think about autism, we're comparing those social behaviors to that intellectual functioning. So that is not necessarily specific to Down syndrome, but because individuals with Down syndrome may have some developmental delays, we want to consider that when we're thinking about their social interaction skills, so that we're kind of being thorough in our evaluation of those abilities. And IQ, when I talk about IQ or cognitive development, it's not just a score on an IQ test, although that can be useful information, but we're also thinking about how somebody is getting around in their daily life. So how are they functioning out in the community, and what are supports that they might need in that area?
You said that kids with autism, they have a regression back in ability sounds when they're 2. And with kids with Down syndrome, that'll be around 5. Do you guys prefer to evaluate a Down syndrome child at the age of 5 or more to have a dual diagnosis, or
So that's a good question. It's really about the age of diagnosis of autism within Down syndrome, and it can vary. So for some individuals, it may be that those symptoms are pretty clear less than 5 years of age, in which case we would want to pursue that evaluation at that time. But because it can be more complex or a little bit harder to diagnose, it may be that individuals are identified a little bit later. And I want to clarify, too, that not every individual with Down syndrome with this co-occurring diagnosis will show a period of regression. About half, from what we know in the literature, may show that. So I think we have time for one more question. Yes?
Well, can you see in an MRI a different configuration?
So I don't know that that has been studied specifically within Down syndrome and autism spectrum disorder. There have been MRI or imaging studies in individuals with autism, and there's kind of a variety of different brain imaging findings. And so I'm happy to connect with you after and kind of talk a little bit more about that. All right, thank you.
Okay, I hope these are my slides. I'm going to follow them if they're not. So, first of all, thank you all so much for coming and joining us today. It just makes this day so important and worthwhile to see everybody come. And hopefully we are providing some useful information to everyone. So thank you all for coming. So I am Brad Christian, and I'm a researcher here at the Weizmann Center. And I want to talk to you about an ongoing project that we've been conducting for about 10 years now, and that's looking at the connection of Alzheimer's disease with Down syndrome. I've given this a discussion on this in the past, and today I'm hoping I can kind of direct you towards where we're going to go. Hopefully we're getting closer and closer to prevention or type of treatment trials. Okay, so I want to just lay out the association first. Some of the imaging that we're doing to measure biomarkers for this disease, and then get more into the study results that we found so far, and finally looking towards the future and where we're hoping to go with this. Okay, so Alzheimer's disease, we'll get to the numbers right away. Just in the general population, it's very rare before age 50. However, there are cases of it there, and that's typically what we call early onset Alzheimer's disease, and that's people with a genetic predisposition for it. Otherwise, if we consider more of our late onset Alzheimer's disease, it becomes more prevalent as you get older, and it isn't until you're in your 80s that we're seeing about a third of the population having Alzheimer's disease. But let's compare this now with our Down syndrome population. Here we are seeing it at an earlier age. I have 9% there in their 40s. And in their 50s, now we're at about a third of the population. So if we contrast that with the general population, we have about the same prevalence, but 3 decades earlier. Okay. And then as we get into our 60s, the prevalence becomes much higher. So we're seeing it higher incidence at earlier stages in life. So briefly, I think everybody here knows Alzheimer's disease when they see it, but a more formal definition, I guess, first of all, for dementia, we talk about a deterioration in cognitive function, that prevents a person from doing their normal daily activities, living independently. And of course, Alzheimer's disease is the most common form of dementia. About 70% of dementia we would call Alzheimer's disease. And that has difficulty in what we would associate with Alzheimer's, typically language, memory, and various cognitive skills. Alzheimer's disease, of course, is a public policy issue. We have over 5 million people, and as our baby booming population gets older, we're going to see more of it. Of course, age is a risk factor, and there's nothing we can do about that as we grow old. The incidence is going to be higher, and of course, our population is growing older, so there are going to be many new cases of Alzheimer's disease coming in the future, and we know that it has a huge burden on society with the healthcare system, and people typically, when you develop Alzheimer's disease, you can live with it for an extended period of time, and there the health burden is quite great. So then the government recognizes this, I think, being promoted by voters too that want to see more action on this. You can see the amount of resources that have been put into it. In the 2013 we have about $500 million, and then it escalates. In this year it's up to $2.3 billion that the National Institutes of Health are committing to Alzheimer's disease and research investigations in that area. So we'll go briefly through the pathology of it. That is, what's going on in the brain, what are we seeing in changes in the cells. So when Dr. Alzheimer in the early 1900s actually did an autopsy on a person that had dementia, looked at the brain, and there were some signature features. And these were what were classified as these plaques and tangles. So amyloid plaques would coat the surface of the cell, and these tangles were more bundles on the inside, and they kind of spread in patterns that were consistent across the people afflicted with this disease. So I'll just briefly explain it and not get too steeped in molecular biology here, but I don't know if I'm going to be able to pull this off with a pointer. Okay, so what happens? This would be a cartoon of a brain cell, and all brain cells have proteins tethered to their surface, and one of them is this APP, amyloid precursor protein. So that belongs there. It's in the cells, and it has a function, and it can be cleaved off by certain enzymes, and normally when it gets clipped off, it becomes the soluble form, and that gets washed out of the brain and all as well. However, there's another pathway with a different enzyme, and that's this beta secretase right here, the purple one. That can, when it cleaves it off, it does it in a slightly different spot, and it leaves behind these fragments, these peptides, that are now sticky, and they can adhere to each other and start to gather together, form clumps referred to as oligomers, and ultimately they can all aggregate together and form these plaques. And these plaques are what can coat the surface of the cells, and that is what Alzheimer saw in the brain when he looked at it. And then the other pathological feature are these tau tangles are called neurofibrillary tangles, and that is, tau protein is another protein that belongs in the brain. It kind of forms the scaffolding of neurons, and it can become degraded over time and gather, and these two can aggregate. Now, these typically are on the inside of the cells, and they can cause damage too. So it seems these features that I'll be talking about are the plaques and tangles, and I'll come back to those. So what is it about Down syndrome that would put them at increased risk for developing Alzheimer's disease? Well, Down syndrome, of course, is trisomy 21, and if we look at chromosome 21, there are a number of proteins that are encoded on this chromosome, and the gene for one of them is on chromosome 21, and I just talked about the APP. That's where it's encoded. So it is believed that in Down syndrome we have an overproduction of many genes, but this one in particular we can attach to significance in Alzheimer's disease. So there's too much of it, and that has been confirmed throughout the years in examining the brain and seeing it later, and it can be prevalent very early. Okay. So if we consider the life expectancy of somebody with Down syndrome, we know in the mid of the 20th century, it was only 9 to 12 years old. There were not medical procedures available at the time, and really didn't, the Down syndrome population didn't have as much access to health care either. And as medical advances were made, we can now see that somebody with Down syndrome born today will expect to live into their 60s or beyond and live long and productive lives. So this all comes with improved health care and access to health care. However, with growing old come the other diseases that are related to aging that are going to emerge also. Of course, Alzheimer's disease is one of them. So, you know, there may be others too that we notice in Down syndrome, but focusing on Alzheimer's disease, this just is more of an illustration of the effects of when a person can get it. I was kind of giving gross categories before, and now if you break it up with age, here and the prevalence, we're seeing most people are developing it at about age 55. It can come as early as the late 30s and later into the 70s. And just like in the general population, it affects the survival of a person. So if somebody has Alzheimer's disease, they will not survive as long as somebody without it. So that's just like in the general population. So now I want to switch gears and talk about our research a little bit more and studying these biomarkers. And just to give you, I'll be using that word, and a biomarker is a biological marker, and it's a medical sign that describes a medical state, and this is outside the patient having to describe it, and it has to be something consistent that we can measure. So rather than a subject describing, well, my memory is not so good, or my memory is bad. It needs to be something you can really quantify, and we have what we characterize as these biomarkers to do that are not so subjective. And the biomarkers for Alzheimer's disease are these plaques and tangles that I had just talked about, and neurodegeneration that also can be measured. And when Alzheimer's first diagnosed, he did it at autopsy, and of course through much of the 20th century there was no way to see these plaques and tangles in the brain until somebody had died and you could actually look at the brain tissue. Well, now with the advances of medical imaging, we can actually detect and measure these biomarkers of the plaques and tangles while a person is still living in a very non-invasive way, either using magnetic resonance imaging or positron emission tomography. So I think everybody has a good feel for MRI. You lay in a magnet and we can measure the different tissue types. Well, with PET, what we do is you can take a drug and label it with radioactivity, put it in a person, and then measure to see where it goes. Now, the key is we only use very, very tiny quantities of these drugs, tracers, so the brain or your body really doesn't know it's there. It doesn't have any kind of pharmacological effect. But all of it hinges on the ability of the drug to go to where you, the process that you're looking at. And that's where a lot of advances have come about in this field, is designing drugs that either go to amyloid and can be imaged or go to tau. And we've been fortunate to make great strides in that area. So our motivation for looking at these biomarkers in Down syndrome is to start to stage and measure the trajectory of some of these biomarkers. For example, amyloid is the first one that we looked at. And we're hoping that these can inform future studies, specifically prevention or treatment trials. That is, if we have a target that we know a drug should try to clear out of the brain, such as amyloid, when should we give it, and is there a way to measure its effectiveness? So we need to first get a feel for how that trajectory is. And lastly, of course, this is the trials that I've been talking about, and the Down syndrome population is well suited because there's a high incidence of a particular disease. So if you can find people that have a higher risk of getting it, you can then focus your trials much better and hopefully get away with fewer people in testing drugs, and that makes it much less expensive to test these studies that are tremendously expensive. So, as I said, we started this study about 10 years ago, and we conducted what was called a natural history study. And these are the first kind of investigations you do when you're looking at a new disease. That is, you need to just see how the pathology behaves naturally and try to characterize that. And we were looking at the amyloid, and shown in the picture is Professor Segan Hartley, who is also an investigator here at the Weizmann Center and a close collaborator on this project. So our goal was to bring in adults that did not have dementia with Down syndrome and just measure the presence of these amyloid plaques in the brain, and then track that with cognitive function that was conducted with various tests. So again, we could then examine the presence of the amyloid and then relate it to how it's affecting how people can function cognitively. We had 79 subjects, and this was a collaboration with the University of Pittsburgh, roughly half of the subjects at each site. Although the participants were older than 30 years, and we, as I said, we conducted the neurocognitive measures and then did our imaging studies too. So for the first day, they would come in and we would do a variety of tests, games that we call them, that kind of probe different components of cognitive functioning. Do they test memory? Do they test your ability to plan or your attention? And then the next day they would come in and we would do our imaging exams. And here is an example of the PET drug that we use, or the PET tracer. I'll call it PIB. It stands for Pittsburgh Compound B, and it was developed by our collaborators at the University of Pittsburgh. So this is a tracer that labels these plaques. We can inject a little bit of the radioactivity in a person and then scan them in the PET scanner. And if we see the presence of this red color in the image, that would be somebody, we're calling them PIB positive or amyloid positive. They have an elevated amount to this. And I want to point out, this is just a color scale we're using to it. It's not going to change your brain tissue red or yellow or green. This is just how we map it out. That throws people off sometime. So it's a little bit of radioactivity. Nobody's brains glow. Nobody glows at all. These are very safe procedures that we conduct. So we found that of those 79, 59 were what we call PIB negative. That is, we didn't see any elevation of amyloid in any of their brains. You don't see any red. This stuff in the middle is the white matter in the brain. We're not really concerned about amyloid there. It's more in the outside or the cortical areas. And then we found about 20 of the total subjects, that is roughly 25% of them, did have the presence of elevated levels of amyloid in their brain. So now we can relate this to the different cognitive tests that they took, and we classify them as PIB positive, meaning amyloid was there, or PIB negative, and look at the different tests where we actually did see a difference between the groups. So even though all of these participants were considered non-demented, there still might be subtle differences that the cognitive tests will show us. But that exam in itself, that's called a cross-sectional study. People come in, you scan them once, and you compare everyone across a group. A much more effective way to study people is something called longitudinal. That is, they come in and you follow them over time. You get much more conclusive results when you look at it in this longitudinal fashion. So we had everyone come in, and we scanned them again, and our original one. So 52 subjects came in at 3 years later, and I want to point out we still had all of these individuals stay with our protocol. It's just at the time that we reported this data, because we were moving on to a different study, we had to stop at 52, but everybody stayed with us. There wasn't that high of an attrition rate. So now I can group these, a slightly different picture here. So what I'm showing is the percent change in this amyloid between the scans that were 3 years apart. And again, I color-coded it, and the green that you see here is really 0% change. So a portion of the people came in once, 3 years later, and we really didn't see very much change in their amyloid, so we're calling that the negative group. And then there were some that were negative at that first scan they came in, but then 3 years later converted to positive. That is, there was a lot of amyloid. And we're calling that group the converters because they converted amyloid status. And then we had the last group of people that had positive amyloid at baseline and then positive at follow-up, and they're just our PIB positive group. And you can see the patterns there. Roughly, we see 4 to 5% increase in this amyloid measure per year over time. And now we relate that to the change in their cognitive testing, that is playing those games that look in different dimensions. And we see in this positive at baseline, positive later group, there were significant changes in all of these, or the tests that we report here in memory as well as other components of cognition. Okay. So that was our natural history study. Again, we started that in 2009. In 2015, we transitioned to a bigger study. That is, the National Institute of Health was very interested in what we were finding. So they encouraged us to continue it and make it larger. That is, bring in more people. So we brought in the University of Cambridge in the United Kingdom and some other sites in the States and made it a larger number, and we increased the biomarkers that we were looking at. So we weren't just going to look at amyloid in this next study we call NIAID, Neurodegeneration in Aging Down Syndrome. So the NIH is advertising this on their website. Here it is, and show the NIH. This is our helper who has just been instrumental in making this happen and bringing this relatively large study together. And I won't go into all the results because this is ongoing and we've just started, but you can see now our numbers are up to 166 people in this. And this slide is just showing the amyloid results. So just to briefly explain it, wherever you see a circle, that is a new enrollee in the project. That is, we only have one scan on them. But where you see the lines, those are participants we've been following over time. Okay. And the red is color-coded to show that somebody is amyloid positive. Blue means they're negative. So I think what grabs your eye right away is, as you get older, the positivity becomes much more prevalent. Right around 40, we're starting to transition into most people being amyloid positive at that point. So we're going to continue to add to these data as time goes on. But another thing, or biomarker that was included in this new study is looking at the tau protein that I was talking about earlier. So just within the last several years, there have been developed these PET tracers that target the tau. It's a trickier target to try to measure in the brain compared to the amyloid because it's at lower concentration. So a lot of trial and error, but now a radio tracer is available. And here are just kind of a summary of some of the findings we find, and I'll take a moment to unpack this a little bit. So each row shows a representative participant. So this would be their amyloid scan, their MRI in the middle, and here would be their tau scan. So the top row would show a participant that was amyloid negative, no amyloid there, and really no tau either. As we go down, I'm showing a participant with more amyloid, and now you can see tau start to become evident in the brain. And that is an area of the brain, the hippocampus. It's involved in memory, storing memories, retrieving memories. So that is starting to accumulate this tau protein. As we go up in levels of amyloid, we're seeing this tau start to spread outside there and start to be incorporated in some of the cortical areas of the brain. And our bottom row shows a subject with, or a person with extensive amyloid and tau present too. So we can relate these to one another. And on this, I'm just showing here would be the level of amyloid we measure, and here is the level of tau, and this would show where we're amyloid positive. So really there is not elevated levels of this tau protein as long as there are smaller levels of or lower levels of amyloid. But once we start to exceed that threshold, now we can see elevated tau in the brain. So this too is, we're continuing to acquire more data on this, and it's helping us form, just what we call conceptual models. That is, exactly what is the time course. So we have to start off proposing a theory, and this is not unique to Down syndrome. This is a trajectory that's shown in late onset Alzheimer's disease too. But in essence, we have kind of time and disease progression, and the amyloid starts off at very low levels, and you start to see a period of accumulation, and then there's saturation. Now, we're finding that tau accumulates after that, same type of trajectory. Now, again, this is just kind of proposing what it looks like. And then after that, we see what I have labeled synaptic dysfunction. It's just showing that your neurons are starting to become damaged in the brain and not working as well. And we have biomarkers that can start to detect that. And then we have death of the neurons. And once the neurons die, shortly after that, now we're seeing the decline in measured cognitive function. That is, your memory isn't working as well. Behavior is starting to be altered. So it's fairly late stage after these early biomarkers become prevalent. So we can use this to decide if we were to try a drug treatment trial or prevention type of trial, to set our thresholds and determine exactly where they should be started and what we should be looking at and what type of time course. So if you were looking at an anti-amyloid therapy, you might start it here. You always want to start these treatments when things are changing. That if it's flat, it doesn't give you very much information. So you want to see it just when it's starting to change. But here too, we now know that this period between here and here is roughly 20 years. So if you're looking at new treatments and the proposition of starting one 20 years early, you need more information on that. That's a very challenging type of drug trial, and you can imagine following someone for 20 or 30 years to try to measure something that's really having an effect. So we can go to tau, and that gives us a little bit of a compressed time window. But what we know is not a very good strategy is waiting till people are starting to show symptoms of Alzheimer's disease. At that point, we're seeing there is substantial cell death that really cannot be salvaged anymore. And we see that often the drug trial results for Alzheimer's disease and the treatment are unsuccessful, likely because starting a bit too late, not giving the drugs a good chance. So this, I hope, illustrates the need for the natural history type of study. We need to know this exact trajectory. We need to know the time difference between all of these things, and that can really help guide these and hopefully increase the chances of a successful trial. So with future directions, I think things look very promising. As I said, the government acknowledges this. Tremendous resources are being put into it. In 2017, they created something called the Alzheimer's Clinical Trial Consortium. And this was just infrastructure that the National Institute of Health set up so that there was trial-ready components for testing out new drugs. If pharma had a new drug they wanted to try, they could use this infrastructure that helped them design the trials and get going right away. What's exciting is we just got back from a meeting where looking to launch a specific consortium dedicated to Down syndrome. Okay? So that's just in the early stages. They acknowledge the value of using people with Down syndrome, that population, to investigate drugs. So I think without a doubt people with Down syndrome can benefit from the research going on. There's a new Include initiative that's just been launched by the National Institutes of Health, and this isn't just with Alzheimer's disease, this is just studying all conditions across the lifespan. And what we're doing, okay, my last figure is not showing up, but there's a study going on called the Diane trial. And that's where I was talking about earlier, people who can get early onset Alzheimer's disease. They have been gathered to form a clinical trial network too, because it's a group that really, knowing the age that their parent ended up getting diagnosed with it, will almost be the exact same as them. So you have a population, you know the trajectory, very powerful for trying to look at treatments and prevention type of things. And that trial has spun off what's called a treatment unit too, and we're hoping the same thing can happen here in Down syndrome. And I'll end it there. Lots of investigators involved in this, but we are not the most important ones. Of course, it's all of the participants and their family, just the most wonderful group of people giving their time that you can ever imagine. Almost everybody has a job. It causes them distress, but they'll take a day or two off from their work and come in and help us out and lay in the magnets and get poked with a needle to draw blood. But incredibly brave group, and we just can't thank them enough. So I can end it there. Thank you. I think I took the full course of time. I'm happy to take questions, but also if you want to break, you can do that too. So, yes?
Quick question. My father has late onset of the dementia, probably from late 80s, early 90s. He died in 95. He wasn't, it hasn't progressed to we had to have him in assisted living for the last 2 years of his life. But by and large, it wasn't nearly what it was if my mother-in-law came down. So I've been involved in testing personally through the Weizmann Center since 2003 when my father died.
Okay.
So my question is this, I'm getting all of this information, I'm part of a study, but at what point does an individual who is starting to have issues with this, whether they be an individual with Down syndrome or an individual like myself, at what point do they let us know that we may be at that point where we need to start doing something?
That's a great question. That's a great question. And I would say, as soon as we know, we're obligated then to relay on that information. And I think I am speaking perhaps too confidently or assertively that we know exactly, well, here comes the amyloid, you're going to get it. What we do find is there's a lot of people walking around with this amyloid in their brain that function just fine cognitively. In fact, if you looked at the older population in the 80s, you would see most people do and seem to handle it. So until we can really determine that it is predictive of something and really starting to tighten up all that information, and it's almost to that point. There's starting to be discussions of informing people of the status of that. But again, we have to know for sure before that information can be relayed to someone. So right now, we say that all of these studies, especially with the amyloid, are non-diagnostic. They can't provide a diagnosis. So I'm hoping we know more, and we will, as all of this data starts to come together. But of course, there's a very broad range, and I didn't even get into this issue of once somebody does decline of cognitive reserve, how certain individuals can seem to fare much better for much longer than other people in that same category.
And the other thing I want to ask about also is that my forgetfulness, my wife oftentimes tells me it's because of my Norwegian heritage, and I'm wondering if there's been any studies as it relates to that.
Haha, with Norwegian. You know, they are active. I know Sweden is very active in all these. No, these studies are being done worldwide. So yes, you know, I hate to say it, I might be younger than you. I probably am. And I get the same thing from my wife, and I hope that's not. I guess we call that selective hearing. Okay. Yes.
There's something called brain plasticity.
Uh-huh.
Marcinek works in that. Do you, that brain plasticity means where they develop a different pathway for these neurons. I'm just wondering your take on that. Is that effective? It almost seems like it's not.
Well, it's throughout the brain, right? So brain plasticity, you know, is also strengthening ones that weren't previously utilized as much. Right. So in a case like Alzheimer's disease, you're seeing the brain is affected, you know, throughout. So kind of strengthening other pathways is more of a challenge. But again, in this area that they call cognitive reserve, it could play a component in that too.
Could you explain that cognitive reserve a little bit?
Yeah. So it suggests that, for example, people with higher levels of education seem to get it later. And that might not mean they don't have the pathology. That just means they might be able to kind of go on autopilot a little bit longer before it's detected. So they kind of have the resources or efficiency in their brain in place that allows it to go and go on reserve. You know, run your gas tank on fumes for a little bit longer. Okay. Yes?
What is your take about people who speak different languages, like us? We are always into languages. Our brain is constantly into languages, going back and forth, with a lot amount of stress during any encounter. We go focusing very much, but then after I finish an encounter, it is like, you know, a wave of, it's a lot of in my brain, you know. At the end of the day, I feel completely wiped. Sometimes I feel it's like, wow, it's detrimental for me. Maybe I shouldn't do that many hours. Maybe that is contributing that I forget things, you know, or not.
Okay.
One study says that if you speak two languages, your chances are less, or what do you think about it?
You know, when you started, I thought you were going to go in the other direction, meaning your brain is working so hard, you know, between languages that would increase that cognitive reserve, you know, the use it or lose it thing. But it sounds like you were suggesting the other way. That struggle was causing stress, perhaps inducing AD, forgetfulness at a younger age. Yeah, I don't have any, off the top of my head, the results of multiple language or bilingual people and the incidence at the age at onset, I don't know. I'm sure it has been studied. Yeah, I think people are raising their hands and they want to answer. Go ahead.
Yeah, there's some research by Ellen Hale's work in Toronto showing that I think the onset of Alzheimer's is delayed by about 4 years. So there's
How many years was that? Did you say?
that it's delayed by about 4 years.
Okay.
So it's not.
Okay.
We take it 4 years.
That's all I need.
Yes.
What are your thoughts about using preventative meds like Namenda at a young age of individuals with Down syndrome? Like even starting between 5 and 10?
I'm sorry, I didn't catch preventive medications like what?
What are your thoughts about using preventative meds starting at a young age for individuals with Down syndrome?
Ones that would potentially affect cognition? You mean preventive meds in that sense?
Like Namenda.
That would be another area I think where we'd have to look at it carefully. I don't have any
Is there any research on
studies. I don't know of any. There might be. There might be. We could look into that, but I don't. I'm sorry, I can't answer that. Yes.
That might be a question for our clinician panel that you could address with our clinicians potentially.
Okay.
So, I'm sorry I just want to keep us true to our schedule. And Brad, thank you so much. That was Again, my name is Teresa Palumbo, and I'm the Communications Director here at the Wasteman Center. And on behalf of everyone here, I just want to thank you for joining us today. I want to make mention, some people have asked me, all of the presentations that are being given today are immediately available on the Wasteman Center's YouTube channel. They're not separated out. We will go through and separate the talks into their individual presentations. Those will also be listed on our Wasteman YouTube channel, but you can immediately go to YouTube afterwards and go through the entire program. We will also make a point to get all of the PowerPoint presentations into a PDF format. Those, along with all the individual talks, will be available on the Day with the Experts webpage here at the Wasteman Center that has archives of previous Day with the Experts events, also not just for Down syndrome, but for the 3 others that we do annually, as Chung mentioned in his introduction. So you will have access to this information both on YouTube and on our webpage. I also just want to say, one of the most meaningful parts of the day, I know for me, is our community panel, which is how we end the day today. The notion of expertise is twofold. We have our researchers and clinicians sharing their expertise, but then the opportunity to hear from individuals and family members who share their expertise and lived experience is also just one of the most meaningful parts of the day. So I hope that you can all stay through the community panel today. Without that, I would like to introduce our next, our final formal presentation as part of the Day with the Experts. Let's welcome Liz Del Sandro.
Thank you. I first want to make an announcement. We have a focus group that's going to happen right after today's events. If you are a person with a person who's an adult, 18 years or older with Down syndrome, or you're a caregiver of a adult child with Down syndrome, we would love to talk to you and get your ideas about healthcare, the quality of your health care or your child's health care, and we are providing lunch. If you're interested, you can join us outside of this room, and it'll be from 12:15 to 2 with lunch. We're just really interested, and this is a part of a broader project that we hope to have going on. We're just getting information from valuable input from whoever is involved, so we can put out a survey later to get more information. So if you're interested, I'll be outside with 2 of our LEN advocate trainees. So excellent. So let's get started. This topic is near and dear to my heart. I'm a speech-language pathologist, and I have found over time that video modeling, video instruction can really be an amazing tool for teaching. And I call it a power tool for learning. Really, this is kind of an important question to ask to kind of determine whether or not you have a child who may benefit from video instruction, video modeling, and we'll kind of clarify those terms as I move along. But oh my goodness, with multiple, your daily life, in your child's daily life, having multiple activities to engage in with multiple steps, does your child complete those independently? Getting ready in the morning, feeding a family pet, ordering at a restaurant, having a conversation with peers, and there are many, many other tasks that need to be completed during the day. And is your child or you having difficulty carrying out all those multiple steps to be successful and be more independent? And that's ultimately what this strategy kind of helps with. So what is video modeling? There are a variety of different types of video modeling, and one straight up definition is it's when a person or group of people are modeling a targeted task or behavior for a learner through video. So they're being taped. I'm doing this, but that's old school. Taped, and they're performing that activity so the learner can watch it through video. Self-modeling, on the other hand, is the person, the learner, actually engaging in that task successfully, carrying out that task, maybe feeding the dog, all the steps to feed the dog at home. And they're being videotaped, and they get to watch themselves, again, do that successfully. Now, they may have needed support doing that, but they're doing it successfully and watching it over, and it kind of builds that confidence and walks them through how to do it. So that's the video self-modeling itself. You're in it. And then point of view modeling is interesting, and I'll show you what that looks like with some actual video. But it's as you are the learner performing it, you see the person's hands performing the activity. So the person, the learner, can watch that video and almost identify with the person in the video, and it's kind of from their perspective. So there are also other definitions. More and more research is coming out about the benefits of video modeling, and these are just, 3 of multiple kind of approaches that are being used to teach individuals. So just to give you kind of some perspective, when I was working as a clinician, I had the privilege of working at a college program that was a 2-year program for individuals with developmental disabilities. And as part of that program, I taught social skills. I facilitated social skills groups. And we used video modeling as a way to teach social skills. And we were teaching social skills for working with your coworkers, your colleagues, how to interact with them, how to ask for help, how to ask somebody out for a date, and that was being video modeled, how to have a conversation or repair that conversation. And what was really cool about it is I had access to graduate students who were the same age as the individuals with developmental disabilities, and we were able to video, and they were able to see videos of people their own age engaging in these activities. And it was a very successful way of teaching the individuals how to engage in this. And it was safe, and you could watch it over and over and over and practice over and over and over. So really, it's one thing I want to say that's really important is it's not a standalone teaching tool. Video modeling needs to be used with other methods like practicing and role modeling and parents or therapists or others providing feedback for the person that's learning a specific skill. But what it does, it's part of a collection of tools that can help your child work towards independence and kind of help your child also prepare for expectations, what's going to happen. Many of us get a little nervous when we're in a new situation and we're kind of trying to figure out what's going to happen to me when I go to this place or that place. Who am I going to meet? What am I going to be doing? Where is this place? What we can do is also use video to help prime or prepare somebody before they go into a situation. So I worked in a clinic where the graduate clinicians changed all the time for the kids who were coming in the clinic or the adults who were coming in the clinic. That can be challenging for a person. I don't know what this person's going to be like. I don't know what they like. I don't know if they're going to like me. What do they look like? So we would send videos out to our patients or our clients before they would come to clinic to introduce. We called them introduction stories, all about me stories, where they could introduce themselves before to the patient, the child, before that person came in. Now, we were a university clinic. That wouldn't be always possible in all clinics, but think about it generally. It could be something where if your child's getting a new caregiver, or your child's going to be working with a new job coach, what about a video introduction to that person, or a video introduction to the place that they might be experiencing or working in. And I'll also today briefly touch on some of the evidence. So I just want to show you a video. One thing when you start with using videos for instruction, start off small, start off simple. Use your tablet, use your cell phone, your smartphone. Don't get crazy into the technology. We all have access, or many of us have access, sorry for that assumption, have access to technology. Make it simple. There are apps that are video editing apps, and you can get all fancy. But don't do that until you get really started with just plain making videos with what you have. And then maybe invest a little bit in the apps. I ultimately like to have videos that also have text that run underneath them, because we're always thinking about emergent literacy, sight word recognition, those types of things. But when you're simply starting out, use simple videos. And here is a simple video about play. Play is one area that we might be teaching kids how to engage in. So this is just a simple video that might be shown to a child to kind of let them know, what are we going to play with today? Maybe they chose this play, and we're going to watch a video of what it looks like.
Oh, let's make hamburgers. Wow. Let's make sure we have all our ingredients. We have hamburgers, buns, cheese, tomatoes, lettuce, and we even have one for me and one for you. Whoa, let's build our hamburgers.
So this is just teaching a possible sequence of play and showing it.
Now, let's get our hamburgers. Put them on the bun. What comes next? Ooh.
So this was simply made with a smartphone. One person, me, trying to handle that and the phone, and it worked out fine. I had to tape 3 or 4 times, but you have to kind of think about what you're going to do to prep for it too. But think about this. We like to do child-led with play. So if the child picked, ooh, yeah, I want to play with the hamburgers, you get out that kit with the hamburger toys and say, ooh, let's watch this video. Let's see how to play with hamburgers. This might be one way to play with hamburgers. But it gives the child an idea. Some kids don't innately know what to do. Now, another idea is if you have siblings or you have peers, ultimately it's way more motivating if you see 2 kids playing together and looking at how they play and make a short video. The next one was play. It's very similar to the first one, and because of time, I'm going to shift to one that's more adult-oriented. So at the Weissman Center, we have individuals who we hire for different jobs. And I would never show this video to anybody that works at Weissman right now. I made this job up, but this is what this is your job video might look like. And kind of this would be something that was shown to somebody prior to them engaging in this job, just to give them a picture of what might happen or what they might be required to do.
One of your jobs at the center is to make sure the patient rooms are clean for the very next patient and his or her family. So we're going to be wiping down different pieces of furniture in the room to make sure they're clean. And at the center, we use gloves, and we also use cavi wipes, and they're on the wall. So first get yourself a pair of gloves and put them on like this. And at first, go ahead and open up the cavi wipes and take 2 cavi wipes and pull and close it up so it doesn't dry out. And now get to work on wiping down the furniture. So I'm going to wipe down this chair right here. Make sure I get all the surfaces.
I might be able to get hired on that. But when you look at that video, I'm giving different information. I'm showing what's happening, but I'm also adding things in there to kind of help the person understand what's being asked of them. But imagine, sometimes you're nervous when you're learning new things, and it might be difficult to retain this information after someone has told it to you face to face. Being able to watch a video is a nice way of reviewing that information. Okay, so just some fun facts. When we think about video has become this amazing phenomena. 5 billion videos are watched on YouTube every day. A total number of hours watched on YouTube each month is 3.25 billion. We are watching videos. We're learning how to knit. We're learning how to repair plumbing. We're learning so many things on YouTube, and we're learning bad things too, and not appropriate things. But YouTube, people are gravitating towards video for learning. The research is saying, pretty much, I mentioned it earlier, that it can be effective for teaching skills that are kind of chained, have multiple steps for individuals in employment settings. It could be teaching multiple steps and activities like cleaning. They did a loop videotape where it continued to play while the person's engaging in the activity, so they could reference it as they were working rather than watching it prior to. And it was also taught to teach skills that might be performed at home in daily living. And there's a lot more going on in terms of the research for specific tasks that are being taught through video, and there's different video approaches. So really, what makes it, what are the advantages of it? It incorporates technology. We have a lot of individuals who are pretty interested in technology. You can view it repeatedly. If you have some challenges with memory, or you're a really strong visual learner, this is something to try out. And it's relatively easy to create if you start simple with the technology that you already have available to you. It also can be really individualized. Know that there are commercially available video modeling videos. However, sometimes learners might have a difficult time looking at that video and actually seeing themselves doing it if it's so different from the environment that they are used to. And it just depends on the learner and how much they are flexible in their thinking, but making individual videos may be more effective than the commercially available. And also, it can just address a variety of areas: living, learning, working, playing. When you create videos, it's a lot of plan, do. You've got to think about, what do I want to video? Is it worth videoing? Is this an activity that's going to benefit my child or the patient or client who I'm working with? So just make sure that you plan and think, is it worth doing this? Once you figure out what the task is going to be, break it down. it's, you know, as a speech language pathologist, I was taught to break things down into individual steps. Break it down, write it down if you have to, and then practice. You have to think about the technology you want to use and kind of your setup. I shot those videos in a matter of a half an hour, those 3 videos. I was kind of planning it out. I made mistakes. I went back. I re-videoed. That's okay. Go back and review it and view it. Try to view it from the perspective of your child and see if it's clear and if there's any things that you might change about it, because it's really quite easy once you get started to do this. When you start doing it, some practical considerations, limit those distractions. I really made it so there wasn't a lot going on. Eventually, you might have distractions because that's the real world, right? But we want the person to focus on really what's being targeted. What skill are you really trying to show your learner, your child? Allow time between each step. Use simple language, instructional language. When you see YouTube videos and people are teaching you how to crochet, they are using very simple language, we hope. Otherwise, you're not going to learn it. And make sure it's relatively short in length because our attention level may vary. And you want to really think about the language level of your child and your child's attention level. And ultimately, you want to show this video right before the activity happens. So it's fresh in your child's mind, and they're kind of seeing what they need to do, and then they're carrying it out. I love this quote, tell me and I forget, teach me and I learn, involve me and I will remember. Ultimately, if you can get to the point where the person, the learner, your child, can be part of the video and perform the task that you're asking him or her to do, that's really, really powerful. That's going to just stay more saliently. It's going to stay in their brains, and they're going to be able to see themselves perform that activity, and what a sense of pride. And to be able to show it to others. And guess what? If they're performing these activities, you can also, this is another talk, but you can also save these videos for a portfolio to show what your child is able to do. So, really quick. We all learn through video, and I'm sure some of you have maybe learned this through video. And let's all do it.
Go!
Oh, I don't even know how to do it.
Not yet!
So anyway, just a little levity. We do learn a lot of things through video, maybe some not as important, but funny. So I really encourage you to attempt to try video modeling. And if you have any questions about that, please feel free to contact me. My contact information is in the handout or the presentation PowerPoint. So, don't want to dig into the valuable time of families sharing their perspective. So I'm going to scoot off, and I'll take questions outside if anybody has questions. Thank you.
I thought it was like, yes, I'll do it.
Clark, waters are on.
I'll answer. I'd be happy to answer that question in case they haven't it to me, but you just read it.
So these are all you guys can
Okay.
just pass them amongst yourselves.
Okay.
When you're ready.
Yeah, you did. That was great. It was really okay. It goes fast.
All right, everyone, thank you so much. We now have our panel of experts from the Weissman Center. Lindsay McCary, our psychologist, Amy Lyle, one of our social workers, and Maria Stanley, our physician in the Down Syndrome Clinic. And I'm Robin Valley-Massey. I'm the clinic manager for the Weissman Center Clinics and the Autism Treatment Program. So we do have a question, and I invite people to ask questions, but one of the questions we received is, what is known about starting a preventative medication like Namenda at an early age, like 5 to 10 years in individuals with Down syndrome to prevent Alzheimer's?
So I'll take that question, and I will say that I can't tell you that I know exhaustively about the research, but I can tell you what I do know, which is that several years ago, for a long time there's been excitement about that compound memantine in mouse models, and there's a researcher named Alberto Costa that's been really involved with that compound, who was initially in Colorado and is now at Case Western Reserve University, and continues to study the potential role of that compound because, again, in the mouse models there has been some exciting progress seen. Several years ago there was a study, I believe it was called the Meadows study, that was a larger study looking at adults who had Down syndrome and monitoring from an age where they were not showing any cognitive challenges to see whether that medication might be helpful in preventing or delaying the onset of Alzheimer's disease. And in fact, that study was stopped early because the people in the control group as a group did better than the people that were in the treatment group. And so, you know, it's a caution for all of us, and I think it shows the challenges as we're looking at translational research, and I think this comes up at about every research conference that I go to, how as good as the models that we can make in animals, they're never an exact match for humans. And we had an experience here too several years ago where we were involved in a clinical trial looking at a medicine that was specifically developed actually for enhancing cognition in people with Down syndrome. And it just seemed so exciting because it had been specifically developed targeting the challenges that we see in cognition, and it was started in people 18 to 30 years and then moved down into the younger age groups, and ultimately, sadly, we found no benefit to the use of that medication. And so, I still believe that breakthroughs are coming, and as Brad mentioned, there are some exciting clinical trials just on the horizon looking at prevention of Alzheimer's disease. And it's not that we're not going to get there, but we're not there yet, and we don't have the answers yet. I do think, though, that the question is actually a great opportunity to think about how do people access those new trials and new information that's coming down the pike. And I just want everybody to be aware of three things. One is that we do have a research registry here at the Weissman Center, and I really encourage anyone to think about signing up for that, because I think it's really important. You can be we can reach out to you to let you know about studies that are happening here at the Weissman Center and how you can be involved. There's never any obligation, and so if you're approached about a study and you choose not to participate, that's fine. There's a national effort called DS Connect that you can access. You can go to their website. It's a wonderful resource. It's really been set up to be a housing for information about individuals and their health care. It's for children, adults of all ages. And researchers can connect with that national website that's through the NIH to request that they reach out to individuals to see if they're interested in participating. And so again, a researcher might say, I'm interested in looking at this new intervention in people in this age group, and if you fall into that age group, somebody may reach out to you to let you know about it. Again, there's no obligation on your part to participate, and researchers are vetted before they're able to connect with families through that registry. And so I think it's just, you know, and then the one other thing I was going to mention is, if you're wondering, for example, is there a trial right now in with Memantine in Down syndrome, there's a website called clinicaltrials.gov, and it shows all the studies that are happening around the country, what are the eligibility criteria, and are they recruiting right now. And so there are lots of opportunities out there, and if you're interested in participating in research, it's so generous when people are willing to give their time or participate, and there are ways to do that.
Thank you. Does anyone have any questions? Yes.
I have actually two questions. One still related to the Alzheimer disease. There is a difference between the lifespan of an individual with Down syndrome that developed Alzheimer and one that didn't develop Alzheimer. My other question is about when a kid has dual diagnosis with autism, that makes the difference academically about what type of academic services they will get, you know, in terms of IEPs and stuff. That would be pretty much the same. It's just like another diagnosis, and it won't impact that part of services.
I can start by answering that question. So the question was about in dual diagnosis, so Down syndrome and autism, how would that change or impact the educational services? And it may or may not is the short answer to that. So individuals with IEPs, that IEP should be individualized to that child's needs to begin with. What can help with the dual diagnosis or recognition of that is it helps other people understand the needs of that individual, so that if they are not already incorporated, social skills or other social aspects might be added to the IEP, or there might be better recognition of that. It can affect the eligibility category, so instead of intellectual impairment or other health impairment, educational autism could be the eligibility category. But the eligibility category is really just a doorway. It should not have that much of an impact on the actual services, because services should meet the needs of that individual child.
And the first question, I think, was regarding lifespan, correct, between an individual with Down syndrome and an individual with Down syndrome and Alzheimer's?
And I apologize. I'm a pediatrician and don't know that literature well. I would expect that there may be shortening in the lifespan just because Alzheimer's is such a disabling disease, and you know, end-stage Alzheimer's affects ability to eat and swallow and do lots of other important things that people need to do to survive. And so I would expect that it could be shorter, but I don't know the literature.
Anyone else? Oh, we have a question.
The only other thing I would add really quick to the IEP question, and it's just another example, is like Nancy brought up earlier, sensory concerns. And if that isn't something that's already being addressed in the IEP, that the autism lens to look through might add some focus to that, and maybe some understanding amongst staff about why that person might be having some either sensory seeking behaviors or sensitivity, or might need a little help in getting going, so be under responsive, and perhaps that would just help highlight that a little bit more too.
That's very interesting, because sometimes, and my kid doesn't have Down syndrome, but he does have an intellectual disability, and sometimes, because he doesn't have a diagnosis like autism, it is like, okay, he's just misbehaving, and then they don't take it as he's seeking for a sensory stimuli or something, or he's just frustrated because he wants to learn and he cannot learn at the same pace that the other ones are learning. And sometimes, and this is gonna be, excuse me if you guys don't understand that, but sometimes I want my kids to have a diagnosis
Mm-hmm.
of autism because there's so many services around that diagnosis that some of the kids that have other disabilities they don't get because of that little piece of just a word that says. That's why I made that question.
And I think we as clinicians have heard that from families before, that sometimes it really does feel that way. I can't speak to how well people are able to access this service, but the way the Medicaid benefit is written currently, autism is not required to receive some of those behavioral intervention services. So they've written it to be more broad so it can be available to people with other diagnoses that don't include autism. Again, I can't speak to a family who's actually gone through the process to try to access that, but it is written in such a way so that we can offer services to a greater variety of individuals.
I love what you said about like this will make people understand the child better because it's just about understanding. It is written is great and it's beautiful, but when we take it to the practices, it's just like they won't understand that part of the behavior. Like, oh, he's just misbehaving, and then they just call mom because we need mom to intervene instead of saying, he just has, other issues and sensory issues that they can just tweak something and then he will keep learning, better. That's very interesting.
Thank you. Go ahead.
I have two questions. The first one's pretty simple. The director mentioned that a third of the children that come to the Weissman Center are students with developmental disabilities. What are the other two? How are the other 2/3? Or what role do they play, or how are they selected?
It's the preschool.
Yeah. So it's the Weissman Early Childhood Program, and it's a preschool and childcare setting, and so the other 2/3 are peers who are typically developing, and families can apply to enroll their children there.
Okay. Then my second question was, we're a bilingual family, and I taught my first daughter Spanish first. I just this might not be your area language, but I'm wondering if, given we got a diagnosis for Down syndrome. And I'm wondering if I should teach my child Spanish first, which is what I did and would have done had he not been diagnosed. But I'm just wondering if you've ever dealt with Spanish speakers and if I'm putting him at a disadvantage by teaching him Spanish first, even though that's sort of what we speak. We can speak, obviously, we can speak English, but I just wonder.
I want to call him Liz.
Liz.
Would you be willing, Liz?
Yeah.
Oh, yeah.
It's important that as a family you decide what's important for your family, and retaining your culture and deciding Spanish, possibly your first language, second language being English. We know there's advantages of children being in bilingual homes. You just have to, in a way, sort of work that out, but you definitely, your child has the right to be communicated in his or her own language, and so we really encourage families to make that decision. It's okay to have both languages spoken, and just making sure that that's also communicated to the professionals who are working with your child. I don't know if you have anything else to add.
Thank you. So the other thing I would encourage you to do is look, there's a website called Down Syndrome Education International, and that group is headed up by a woman named Sue Buckley, who is a psychologist who's also a parent, and has really been an amazing advocate for appropriate education and care for people with Down syndrome in the UK, and she and around the world. And she, but on that website are some really nice resources about bilingualism and Down syndrome, and some really helpful information. I think what Liz said too is it does come down to an individual decision, and sometimes it comes down to who is the child that you have, and if at some point you find that child is struggling with bilingualism, do you then choose just one primary language and work on that first? But I think a lot of families have successfully raised their children bilingual with Down syndrome and been happy about that choice.
What was the website again?
Down Syndrome Education International.
Yes.
I have a question about the Wiseman Center Down Syndrome Clinic. We have attended that clinic for several years with my 7-year-old and have been absolutely thrilled with some of the opportunities that have come out of it that I don't think we would have accessed otherwise through our wonderful pediatrician. One of my questions, and I don't know if other families have this, is when, as far as the range of services and your opportunities that you offer for children, things like our hearing screening and speech evaluation, all that, when do you typically see children age out of that Down syndrome clinic? How do we make that decision when we're utilizing that time valuably or when it might not be beneficial anymore?
So I can start, yeah. So in terms of when somebody could join the clinic, we typically aren't accepting new patients into the clinic over age 18 at this time. It is a goal and a wish and a sort of a driving goal, I would say, to think about how do we start to provide care for for adults with Down syndrome. In terms of we do have some flexibility in the clinic right now in terms of care for older individuals. I think being a pediatrician in general and being a pediatric clinic, our comfort level is really with people in childhood and not into adulthood, although I have done some consultations with young adults, but I think that ultimately, our hope is that we will be able to provide lifespan care here, and we're actively seeking information, which is part of what Liz is doing to try to understand what are those adult health care needs.
And I would just add, typically the age that we start to look at transition is between 18 and 21. Yes.
Does eye contact come in as a Down syndrome issue at all, or is eye contact something that's unique to autism? We're trying to look at the situation.
So eye contact is interesting because the lack of eye contact or more intermittent eye contact can be due to a lot of different things. So some kids who have a lot of anxiety or who are inattentive might have limited eye contact or fleeting eye contact, as well as individuals with autism. So when we think about autism, there are thousands of different ways that symptoms can combine to meet that diagnosis. And so eye contact is just one piece of that. So I would say in general that if that's the only behavior that seems different or concerning, then it may not be something to worry as much about. But if there are multiple behaviors, then I think that's when you want to start asking that question.
And for older children, I'm speaking for myself as well as a friend with a teenage daughter. My son is 13, but I was never really concerned with getting an autism diagnosis. He came to us older, and so I wasn't concerned with that because I felt if we could meet his needs, that's all that mattered, looking at what are his specific needs. Is there any benefit to having older individuals with Down syndrome diagnosed with autism if one feels they might be on the spectrum somewhere?
I'll let Dr. Stanley talk to this point as well, but in the literature with individuals with autism without a genetic condition, there is a lot of value in understanding that diagnosis and getting an evaluation when they're older. Not necessarily for treatment services, certainly those could be available if they so choose, but to understand what their differences are and how that might manifest or affect their interactions with other people. There can be some value in that information at an older age. I don't know if you want to add anything.
I don't really have much to add. I would say I'm not aware of any literature that specifically answers that question for us, but I think that the lens of understanding that the challenges that are unique to that particular individual can always be helpful.
And I would just add, when we think about employment in future and the more caregivers outside of the family that might be interacting with older individuals with Down syndrome, that might also help them better understand the individual. If we know that if they also have autism, that can go to kind of what Liz was talking about with video modeling and ways that tasks are taught, ways that caregivers are introduced. We know that visual learners, that can be such a strong tool, and that if autism is sort of on top of that, that could be incorporated in lots of ways in their adult life.
Anyone else? I'm wondering, we still have a few minutes left, if the panel would mind telling us a little bit about what the Down Syndrome Clinic does.
Okay, I can talk about that a little bit. I'm the clinic coordinator for the Down Syndrome Clinic, and so we see families who have kids and youth and young adults with Down syndrome, and typically we meet as a team twice a month at this point. And on one week, we see kids who tend to be under the age of 6, and on the other weeks, we see older kids. We are a multidisciplinary, interdisciplinary clinic, so we have lots of team members, which is really wonderful. We value that as clinicians, having each other to rely on and inform our experiences and recommendations that are made to families. And we, I think this clinic is so near and dear to all of our hearts because we learn so much from families and kids that come to our clinic as well. So we have Maria is our, Dr. Stanley is our medical director of the Weissman Center, but also our clinic director of Down Syndrome Clinic. I am the clinic coordinator and also the social worker in that clinic. Lindsay, Dr. McCary is the psychologist in that clinic. Liz Del Sandro is the speech-language pathologist. We also have physical therapy in that clinic as well as occupational therapy. We have nursing in that clinic. And we all come together and we try to reach out to families ahead of their appointment here at Weissman Center to really hear from you all what your priorities are for that visit. It tends to last an entire morning, so it's usually sort of like an 8:30 to noon, 12:30 experience. So it's quite a long morning, and we definitely want to make sure that families leave with their questions answered and their priorities for the visit addressed. So we try to do that. If there are ways that we can make kids and families more comfortable in clinic, we want to learn that ahead of time too. We also more recently have been able to add a few MD-only appointments or doctor-only appointments to Down Syndrome Clinic with Dr. Stanley. And so a lot of times we are seeing babies who have graduated from the NICU, and those appointments as a way to welcome those families and provide some of that post-NICU developmental monitoring. And then they would be seen in a team appointment later. We have audiology. How could I have forgotten audiology? Yes, so audiology is a huge part of that appointment too. Yeah.
Every kid that gets diagnosed with Down syndrome around the Madison, Wisconsin, I don't know how you call it, Dane area, come to the Weissman Center, or not every kid with the diagnosis will come?
Definitely not every kid with a diagnosis comes, and we wish that our capacity was such that could be the case. We would love to see every family who has a child or youth with Down syndrome, and our challenge right now is capacity. We don't currently have the resources to see families as often as we would like, and there is a wait to get into clinic, and we are working on that and problem solving around that. Mm-hmm.
And I would just add to the gate into the clinic is definitely a referral from your primary care doctor. And so, the other kids that we're not seeing, it's not because we have screened them out of clinic or declined to see them. It's because they haven't been referred to our clinic. And so that's the way to get in.
There are also some challenges with insurance as well. So you can always call and speak to me if you're concerned about that. Yeah. Okay, great.
All right, well, we're almost at time, so I think we'll wrap up, and thank you to our panel.
We got enough space?
Oh, we did. Yeah, we did.
Do you want me to come up there? Okay. Sure.
So we're going to transition to our community panel. One of the ways that makes days like this possible is through our partnerships with community organizations. And this year, we're delighted that it's our 9th year doing this in partnership with the Madison Area Down Syndrome Society, and this year too our additional partner is Gigi's Playhouse. So we're grateful for the opportunity to work collaboratively on this event and in so many other ways. Our moderator today is Joe Bridges. He's the president of MADS. So I'm going to let him take it from here, but let's give our panelists a warm welcome.
Hi, everybody. Thank you very much for being here today. Like Teresa said, this is one of the highlights of the year for us at the Madison Area Down Syndrome Society. And on behalf of MADS and on behalf of our co-sponsor for the event, Gigi's Playhouse, we want to thank the Weissman Center for not only putting this event on, but for everything they do for the Down syndrome and disability community generally here in Madison. So just a little bit of background on myself, and then we'll move on to introducing our panelists and getting them to tell you a little bit about themselves and why they're here today. So I've been the president of MADS for a year and 3 months now. Joined the board in 2015 after my daughter Kennedy was born. Kennedy is a vivacious firecracker of a 3-year-old who also happens to have Down syndrome, and she is the reason why we're here today. So the reason why I'm here today, I should say. By day, I'm a senior litigation attorney with the law firm of Michael Best. I'm also active in the Down syndrome community at the national level with the National Down Syndrome Society through their ambassador program. In fact, I was just in DC this week lobbying for legislation that could have a positive impact on individuals with Down syndrome and their families. So with that, let's get to who we're really here to talk to and about today, our panelists. And I'd like everyone to introduce themselves, tell us a little bit about yourself, and we'll start with Caitlin Widdish. Caitlin, could you tell us a little bit about yourself?
Hi, my name is Caitlin. I'm 24. I live in my own apartment, and I am a cheer competitor.
And Caitlin, you also have 3 jobs, right? Yes. Can you tell us where you work?
I work at DOR, it's Department of Revenue, and I work, the second job is Walgreens, and my third one is Mod Pizza. If you go there, they have very special pizza there.
And Caitlin is, of course, being modest, especially with regards to her job at the Department of Revenue, where she does inventory management, but also data entry and records management. So really important and, frankly, intimidating work, as far as I'm concerned. Caitlin, thank you for being here. Sadler, can you give us a brief introduction, please?
Yeah, it's all about, I want to say, roll tide, all you Badger fans. I am from Alabama originally, that's why I said that. I'm actually 35 years old. I just had a birthday on Valentine's Day. But I actually moved here from Alabama when I was only 19, and I've been living on my own ever since then. When I first got here, my sister was going to UW as a grad student, actually, and I was a senior in high school, and we all know how it is when you're a senior and you're about to go to college. So I actually called my sister and said I pretty much got everything I could here in Alabama. So I told her I needed to move up here and make a change. So it was really hard for me to actually say goodbye to my family and my friends, especially my mom. Because I know there are a lot of moms here, and I know that if you have a child with a disability, especially with Down syndrome even, it is still hard to say goodbye to them when they leave the nest.
And Sadler, can you tell us a little bit about what you do professionally, where you work?
I actually work for the DOA, Department of Administration, as a mailroom clerk. I basically meet a mail. I actually get Caitlin's mail, actually. I actually do get her mail. From her job. And I also have a seasonal job that I do for the senior justice office at downtown, actually, doing data entry as well. And actually, I'm working on a project that I want to have my own nonprofit to teach old people with disabilities to actually learn how to live independently. But it'll be a couple of years because, like I said, I'm just starting out.
Thanks, Sadler. And then also joining our panel today, we have Susan Moore. Susan, can you tell us a little bit about yourself, please?
Hi, I'm here as a grandmother. That's my claim to fame. I am a registered nurse. Been a nurse for quite a few years, but I have a beautiful, actually two beautiful, 5-year-old grandson and Jacob, 2.5-year-old grandson with Down syndrome. And I'm here as a grandparent.
And we're really excited to have that grandparent perspective because I know it's been a number of years since we've had a grandparent on the panel. So thank you for joining us, Susan. Also, Caroline Skalski. Caroline, can you please introduce yourself?
Hi, my name is Caroline Skalski, and I have a daughter who is 16 with Down syndrome. Her name is Isabella, who is active at Gigi's Playhouse. Loves Gigi's, would tell me it's her second home. And she has been homeschooled all through her schooling years, and so by day I'm a homeschool mom, and I live in just south of Oregon.
Thank you, Carolyn. And then our last panelist joining us today is Amy Ulrich. Amy, could you please introduce yourself?
Sure. I'm the sibling of the crew. So I have a brother, Chris, who is 9 years younger than me and lives in Madison. And Chris and I live together. After our parents passed away, I moved back to Madison from Colorado and assumed guardianship and caregiving duties, and I work also full-time for the Department of Justice. So you also do my mail.
Yes, I do. And I know how it feels also actually to have a sibling that also worked with people with disabilities. You might have seen my shirt. It's Living Their Visions, Love Dane, L-O-V Dane. It's actually an organization for all people with disabilities. And my sister was one of the members that actually first started it. And it is actually was one of the, also part of Weissman Center as well. So if you want to check out Love Dane, lovedane.org. For all people with disabilities, it's family-based, and we don't judge no matter if you're Catholic or Jewish or anything like that. We don't judge people with that kind of thing.
And Sadler just very helpfully answered the first question we had from the community, which is why he moved to Madison specifically. And he came here to work with Love Dane and work with his sister, who was one of the founding members.
Well, it took a while for Love Dane to get started at first, but yes.
And so the first official question I think we're going to have is for Caitlin and Sadler, and I think we'll start with Caitlin. Caitlin, what is it like, and could you please tell the group what it's like living alone in your own apartment and what you really appreciate and like about that?
I live in my own apartment because you do more chores at home when you have really hard chores like laundry and dishes. When you have more chores, you have to get done a lot of laundry done. You get a next one and another one done. Now you get free time. If you do free time, yeah.
And Sadler, same question for you. What's it like to live independently, and can you tell us a little bit about your roommates and how that goes?
Well, I think no offense to the mothers, I actually loved what I left the most. I actually was the only one in my family that she was looking more forward to it. But for me, I just love being on my own. The two guys I do live with, one guy's in my basement. He actually worked at a cheesecake factory, if you love cheesecake. And the other guy, he's there for a few more weeks before he goes. He's actually a software engineer for Land's End.
And now we're going to have a quick question here. Carolyn, I'm interested because I know you homeschool your children and have homeschooled your daughter Isabella, who has Down syndrome. Based on that experience and kind of what you've learned, what is one thing that you'd like to tell teachers and schools in the public system or the private system about having a child with Down syndrome in the classroom?
I would want to tell everyone to always be able to step outside the box. No child with Down syndrome who I've ever met is the same. None of them are the same. And even with my own experience with my 6 children at home, and they range in age from 24 to 11, so I'm still homeschooling 3 of them. They all have needed something different. There's not one program that fits every child, whether they have a disability or no disability.
I agree with that because my parents do that for both me, my brother, and my sister. And that's the easiest one.
So be willing to step outside the box. Be willing to look at something from a different angle. And don't hesitate to be the person who advocates for your child and says, no, this isn't working. We need to find something different. That's...
I have a question for you. Very nice to meet you.
Sure.
Recently in January, we start having my son having online education at home. It's not homeschooling because it's not us, it's just the school district.
Sure.
Because he was having numerous issues at this school, and then he went to a specialized school that was even worse. And how did you handle the social part of being at a typical school than being at home?
Okay, well, a few things. One is Isabella is the 4th in 6 children, so there's a lot of kids at my house. And I mean, just by chance, I guess. So the social aspect for her, I mean, she always had kids around all day, every day. We also belong to a homeschool group that has more than 100 families. So we get together very frequently and would go on field trips together, just like schools take field trips to many of the same places. I mean, so we do a lot of that. But also, the other way I deal with socialization is I go to the park. I get my kids involved in the community. I'm at the library. I take my kids to story time. You know, just all the things you would normally do in a day. I mean, we go to the library during the school day. We talk to people. I don't isolate my kids. They're in sports, they're in, we're in the community.
To be part of that homeschool group, you need to be part of a program,
Yes, for ours, yes. And there's a lot of homeschooling, and I can talk to you afterwards. There's a lot of homeschooling resources in the Madison area. There are. Sure.
So this question is for Amy. How did your family plan for your eventual role as a caregiver? Or what steps did your parents take?
They did not plan, and they took no steps. So,
do you have any recommendations?
Yeah, I have quite a few. Where would you like me to start? So, my father died very unexpectedly of a heart attack in the backyard of our home after dropping my brother off at work, and I knew when I was in high school that this would be my role. And what I can say to parents is, if you have a sibling who expresses an interest in being a caregiver, don't push it off. it's real. And any sibling will tell you this, that if they have an interest, I'm part of many sibling groups, and there are many siblings who have a strong desire to take on the role of a caregiver when the time comes. And my parents, I expressed that repeatedly, but my parents kept pushing it away. They didn't want to talk about it. They didn't want to think about it. They didn't want to plan for it. Maybe a state of denial, I'm not sure what. But if you have a sibling who expresses that, honor that. We're not kidding. We want to take on this role. I love the role that I'm in right now. It's one that I've always known that I was going to play. But what would have been helpful is if they had helped me plan for it. Things like coming up with a care plan, coming up with understanding why Chris does things the way that he does them. I had 2 years after my father died to establish guardianship, because they had never even done guardianship for him. He had no guardian, and he was 37, and he had no formal guardianship. We had nothing, Social Security, banking. It was pure crisis when Dad died. Social Security cut off his payments immediately when my father died. So we were in a state of crisis. There was no special needs trust for him. There was no plan. So I spent 2.5 years working with lawyers, getting guardianship established, and coming up with a plan. There was no housing for him. He doesn't live by himself. He lives with me, and that's because none of that was done prior for him. So a lot of siblings do find themselves sort of in a state of crisis after the parents cannot care for them anymore. And if there's anything you can do to help your siblings or whoever you want in the future to care for this individual, do it well in advance. It just makes things so much easier for everyone.
I want to add to that, actually, because for me, I was lucky, actually. My dad actually worked for a lot of banks growing up when I was a kid. So he has helped me, and my sister has helped me with my money. And my brother, he actually turned himself completely from one side of the tracks to the other, from having problems with drug and alcohol, from having that and overcoming it, and becoming a counselor to helping others to not make the mistakes that he made. And my mom actually is a retired physical therapist, actually, and they always helped me. Actually, in Alabama, they have segregated classrooms, basically, back in the 90s. I'm not sure how now anymore, but back then, no matter how old you were, there was one class just for the people with disabilities, even with Down syndrome or autism. And I really want that. So my dad was the first person ever to advocate for me. He went to all the board meetings and says, my son has Down syndrome, and you better be ready for him.
Same thing like me. My uncle passed away. He would support me too also. He lives in Arizona, and his name is Charles, and I don't know what happened to him, but I know he would support me. My aunt name's Aunt Shelley. She would support me also too when I go down there. They support me down there. When I have disability, they would help me with cooking skills and different stuff also. Yeah.
And do we have a question over there? Yeah.
So for Amy, so I'm new because my sons are younger. Does everybody need to establish guardianship once you have a child that's over 18, or what?
My understanding is that there's different levels of guardianship. There's some newer things some more self-directed guardianship. But Chris is very cognitively affected by Down syndrome. He has probably the IQ of a 3-year-old. And he's 41. He needs extensive care, but he's also incredibly social and can be manipulated very easily. So the guardianship became an issue, especially around issues around banking. My father was a very social guy, and everything kind of their generation was a wink and a handshake, and they just made it work that way. But when he died, the banks would not, we couldn't, Social Security was like, where's the paperwork proving that my mother could become his rep payee for his Social Security payments? Where's his separate bank account? Times have changed. Everything's got to be documented. Everything's got to be in writing. And we couldn't even talk to his doctors, because we just didn't have anything. We had nothing. Whereas my father kind of worked on it. So the guardianship has really helped smooth everything for us whenever we had to do anything legal or banking related.
I'm actually my own guardian.
Yeah,
actually. And my sister actually has helped me with money. My dad with money. My family has really allocated. And if you have like another sister of having a brother as well, like my sister does, with Down syndrome, it's basically like, what do you want to give up on a family member? Hell no. It's family.
We have another question towards the back there.
Just a tiny addition. There is going to be a presentation on March 21st hosted by Love Dane, which is going to cover some of the alternatives to guardianship, like supported decision-making, use of powers of attorney. You can go to the Love Dane, LOV-Dane website and look that up.
That's lovedane.org. It's lovdane.org.
Yeah, lovdane.org is the website. And it's going to be at night, and it's going to be at it's a church that's just off of, I can't remember the name of the street.
It's Orchard Ridge.
Orchard Ridge, thanks.
And we also, MADS also does every couple of years, and we're looking to do it again this year because it's been a few now. We do a financial planning and special needs trust seminar that's always been really successful. I know I went after my daughter was born, and it was super, super helpful in getting us on the right track. So just keep a lookout. I mean, we're really fortunate to live in Madison and in a community that has a lot of these resources at your fingertips if you just look. I think, Carolyn, you wanted to add something?
I just wanted to say that I also have a brother who has a cognitive disability, and I would tell you that when Amy says that her brother Chris could be taken advantage of monetarily, my brother has been by friends, supposed friends. So I think that is something to really just be aware of, realize it, and make sure you take steps to protect them.
Yes, and that's one of his father, his sister actually started Love Dane because of me. And people like Caitlin, we have a disability, but there's a t-shirt I have. I don't have it on me, but it's called Later Jaws, Not People.
Mm-hmm. So I want to shift a little bit to talk with Susan for a minute about her perspective as a grandparent. And Susan, I guess I would just start with, I know when my daughter was born, my parents and my wife's parents struggled a little bit with how to process the diagnosis in a way that gave us some space, but also that kind of recognized what an impact it was going to have on our lives. And what we often hear, I think, in our community is that grandparents aren't really sure how to react, or do I treat the child with Down syndrome differently than my other grandchildren? How do we deal with this as a family? So I guess what was your experience, and do you have any advice for grandparents who are dealing with a new Down syndrome diagnosis in the family?
That's a great question because, being a nurse, you have just enough knowledge to be scared. My daughter is a physician. She had even more knowledge to be even more scared. So we sort of navigate it together. I mean, the positive side is that you can navigate the medical system, the hospital. I mean, I do have, a little bit of knowledge of how it works and, how to communicate with caregivers a little better. They do so that's a piece. But the bigger question, I guess, is that first reaction, and it's hard. It's something that you don't expect, but it's your family, and you're just going to show support and love. That's all you can do. Right?
And, yeah.
I'd like to add to that. It's a tremendous shock. It's a shock to the parents. It's a shock to the grandparents.
It is.
And personally, I didn't know anything about Down syndrome. I don't know a lot about disability, even though I've been in the people business my whole life. I've been in the people business without the people who do not have a disability that they accept. The point that I'm making is that I think that I found myself questioning initially. My gosh, Noah has Down syndrome. That means he'll never live in our society. He'll be shipped off someplace. And I even felt a part of myself believing that. And I'm ashamed to say that. So I think what's important for all of us is to understand that people to believe, to inspire, and to educate ourselves. The first step is I had to believe that Noah was a human being. And Noah inspired me to learn more about what it meant to have a grandson who is a unique person, like all my other grandchildren. And that, the rest is history as it relates to that, and it evolves. It's evolved today from what Caitlin and Sadler have said. It's evolved, Amy, from what you have said. It's evolved as I've seen parents who are decided to be educated at home. Bottom line is, I'm sorry I could talk about this all day long, but the bottom line is that all of us need to realize that any person born is a unique human being. And as a unique human being, they deserve our respect, and they deserve our love, and they deserve our ongoing efforts to help them be all that they can be, just like that's what we want in our lives.
Well said.
That is great. I just want to make one other additional comment, because I do feel like that with the medical complications that go along in that first 6 months or so, we can get completely wrapped up, or I got completely wrapped up in the medical component of it, and so I pushed all those feelings back, and so then 6 months later, then I'm dealing with what you're talking about, and you're right. I mean, and that's probably the nurse in me going, "Oh, I can fix this," But then 6 months later, I'm dealing with all of those, and I applaud you for saying it so eloquently, because that sounds like it came from my heart.
And then, Susan, what, in addition to the love and support that we were just talking about, what have you found to be most helpful in terms of helping out your family, right? Because what have you been able to do that's eased the burden on your daughter and your son-in-law and your grandchildren?
Every grandchild is unique, as you mentioned, and they all have different needs. For me, it's just being a grandmother. I do what all grandmothers do. I, babysit. I transport. This morning, the older spent the night with us. We had a great snuggly party last night, and I dropped one off and picked up Jacob, and we went to Gigi's for Special Olympics and literacy, and then I'm here. So, you just do what grandparents do. I try to help Jessica with, like the first 6 months or so, we provided a cleaning service, because I think those are the things that do help. We try to encourage them to go out and have time on their own as much as possible, because then we get the kids and we're excited. It's a win-win for us. But I think just being there is the main piece, being used as a sounding board. And I know that sometimes it's hard for your mother to be your sounding board, but she and I fortunately have been close enough that she can do that. I know she does it with some other great support friends too. And Mads has been amazing to have that support for her. But yeah, I just am a grandmother. That's what I do.
Hey, so Caitlin, I have a question for you, because you're so independent. You have 3 jobs. You're a competitive cheerleader. How do you get around? So how do you get around town? How do you get from your home, your apartment, to your jobs, to your cheerleading? What's that like?
For cheer competitor, I get trophies if you win. We won last week and we got first place.
Nice.
And for home and work for transportation, I take transit solution. If Down syndrome use transit solution to different work options.
So you're able to use that to get there when you need to get there.
Yeah.
And Sadler, how about you? How do you get around?
Well, several ways, actually. My favorite way is coming up in a few months. I love to ride my bike, pretty much anywhere. And I get around with like cab systems, like Unicab. I get around with Van Gogh. I actually have my heard of Iris and Family Care. That kind of came in just this past year, and well, over a year ago actually, I believe it was, and that for me was a change because I used to have the services that Caitlin had, but then after that I have Van Gogh, and for me, I'm kind of like my father when it comes to being a little bit clumsy, especially on ice and snow. So I have rides that will pick me up, going to and from work and whatever place I need to get to, because I'm pretty active in pretty much anything I do. Because I also love to do meditation as well. I also get around with family that, for rides. I even got an offer to ride home today from Bill, the president of GG's.
And so it sounds like you guys get around just fine.
Yeah, I do.
And so then, Carolyn, since Isabella is 16, I'd have to ask you whether she's expressed interest in driving and kind of how you guys have decided to handle that.
Yes, she has. She intends to drive and get her Mini Cooper as soon as possible.
Should not drag.
You know, we have talked to Isabella. She has 3 older siblings who drive and all have their own cars. And she understands that, well, she doesn't understand. She hears us tell her that until she can make quick enough decisions, that is not an option at the present moment. And my brother, who has a cognitive disability, he lives in Illinois, and he went through a program where he started taking driver's ed at like 18 and a half, and it was a year-long program that he was in. I have to ask my mom more specifics, but our decision for Isabella is if we believe that you can get to this point and make good decisions, because it's not your safety on the road that but there's all the other people driving on the road.
I strongly agree. I actually have not done this permit in Alabama, and my own car, which is always a teenage dream.
So I'm not sure she'll ever, be able to drive. I just don't know.
Yeah, and I know I've heard actually lately about a lot of people falling asleep on the wheel. Yes, I have. Thank God my dad was there to take over for me.
And something I often think about, Carolyn, I'd be interested if, and maybe you've already answered it with your what you were just talking about there, but I think we always strive to tell our kids that they can do absolutely anything, and certainly anything that their typically developing peers can do, but I think with driving, I think we often think of it as much more of a safety issue. So kind of how have you navigated the distinction there without making it sound like Isabella can't do something she wants to do? Right.
We haven't told her no, but you're right. You spend your entire first 15, 16 years saying, you can do it. You're just like everyone else. Might take you longer, but you'll get there. And then when you have to backpedal on this, we have not said to her, Isabella, you will not drive, because I can't really determine that right now. Will she drive? I'm not sure. Do we tell her, Isabella, can you make a split decision? Yeah, Mom, it's easy. I watch you. Well, sure, it looks easy, but she does have older siblings who will say to her son, or her brother, Elijah, who, thought everything looked easy, and then he got behind the wheel. He's like, whoa, there's a lot to pay attention to. Well, there's actually cars in front of you and behind you, to the left of you and to the right.
That was hard, even like myself, because I actually have ADHD, and that's even harder when you're behind the wheel, having Down syndrome and ADHD.
Right. So again, we just let her know that we'll cross that bridge when we get there, but right now, this is, not an option for you.
So, you have a question? Yeah.
I do. And I go back a few questions. As a parent, the 1-year-old didn't know this diagnosis was coming at all. And to think about planning for the future, like on top of the fact that of everything else, I have no idea what to do about guardianship, estate planning, all that. It scares the crap out of me. What can you advise?
So I will say that I have a 3-year-old, and we still haven't finished the process. I'm somewhat ashamed to say, but also like willing to say, because it's just so daunting and so intimidating. And I mean, like I went to law school, and I have no idea how to navigate some of this stuff. So what I've found is that we've found people that we trust that can help us with that. And I'm happy to share some of those contacts with you. We have working with some wonderful people that we've made contacts with. And then again, just keep an eye out for the Love Dane program is going to be a great resource, and the MADS program that's going to be coming up later this year. And I think that's the best place to start, is just try to get the information. I would stress that while it's really important to do it, I don't think it's it's not very productive to put a lot of pressure on yourself that makes you kind of freeze up, right? So try and get help, try and ask people. That's what's worked for me. Yeah.
So when I found out my daughter was in utero, and I was obsessing over every single thing that could have happened to her. I read all the medical stuff, and then as soon as she came out, I was on the internet trying to think, okay, well, I've got, she could get Alzheimer's at 35, and she was just 5 months old. So I had a friend suggest that, I get her enrolled in the programs for their wait list, like family support and things like that. Things in her immediate future, but just give yourself a year for the other stuff. She's so little right now. You don't need to start thinking about that so much. Now maybe when she's my daughter's 10, and I'm we should sort of maybe start paying attention. So I just breathe. I mean, it's out there, and I think it's so good to hear this, but it is, I just want to echo Joe and just take a little bit of the pressure off.
Live in the moment. Literally, live in the moment, enjoy her. She's only won once. And there are people who will help you navigate this. If you get involved with family support, they will walk you through it. So, yeah. And I know, because I'm about to walk through it. So just breathe. Don't get too anxious about those things.
So I feel like this is, go ahead, Amy. Yeah,
and I would agree with that. It's fine. You're going to be fine. Just please don't wait until you're 75. Please. So, yeah, and I think that the more you can get involved with groups like Love Dane, and MADS and GG's, the more resources you can bring into your family, grab them, just grab hold of them, because there's so many people out there that will help you. We were in a situation of crisis. I didn't even have time to grieve my father's death because I had to get to work, and I had 2 years then before my mother passed. So it was boom, 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 So don't do that to yourself. Don't do that to your family. But you have plenty of time. And once I found the right person to call, it all just kind of came together. But it would have just been so much nicer if they could have helped me a little bit with it. So it'll be okay. But there's so many resources, and that's why Madison is so great, because it's a small community, and Wisconsin is a great, area. There's so many parents and family members that will just step you through it all.
I think this was an awesome natural transition point to something I always like to ask and discuss, is kind of what, as caregivers, but also as our individuals with Down syndrome on the panel, what do you do in terms of self-care to kind of relieve the daily stresses that come along with, having the responsibilities that we have? I mean, I'm a big movie guy. I like to sit down and watch a movie. I like to play golf. Just stuff that I used to do before Kennedy was born that I just try to focus a little bit more on now. So I'd be interested, anyone who wants to take that one, let us know what you think.
It's hard.
Mm-hmm.
It's really hard. But my situation is a little different because I do live with Chris, and so I have a lot less time for myself. I've turned into a mother again at the age of 50, and so things that I liked to do before when I lived in Colorado are out the window. But what I do for myself when I can is I work out. I used to go to the gym for 2 hours. I can't do that anymore, and I've lost that. It just can't happen. So now I work out at home. So it's making changes like that. But self-care it can be really hard for caregivers. In all honesty, I guess it's finding support, I'm fortunate I have a husband who's with us and hasn't left me yet. And so he'll take Chris for a break, so I can have a break now and then. But self-care is usually at the bottom of the list.
Yeah, I find that the thing that's helped me most is I've just started asking people unabashedly to spend some time with Kay or to come and help me out, and more so than I ever thought I would, and just not being embarrassed by it or upset by it.
I think respite resources are a good plan. I also think, though, and coming from a parent's perspective, and note that I have 6 kids, as parents, I take that role of sacrificial love pretty importantly. And, you're devoted to your kids and your family. So when you walk in there, and yes, I didn't expect a diagnosis of Down syndrome either. For those of you, some of you may have known and some of you may not have. But I do firmly believe that God gave you the child that you needed to have and that child needed to have as a parent. So I think you have to remember to always take care of yourself, but also remember that there's sacrificial love and just how important that is. And to remember to make time for yourself, your spouse, your other children, if you have some, but also remember that they were given to you for a reason. So, embrace it and walk through it. The good times and the bad. There's always good times, and there's some pretty awful ones too. When Isabella had infantile spasms, I thought it was pretty awful, but you just get through it. And I think as they get older, it's more important to have respite as they get older. I think when they're young, no offense to all you parents with young children, but it is a little, in my opinion, unless you're having a lot of medical things, it's a little easier, and people are a little more willing to take them. I think sometimes when they get older, it gets more difficult, and so you just have to find ways that you can, in the community, or things that they can go to that will allow you some time. And get enough sleep. I can't stress that enough. Sleep's essential.
So Sadler and Caitlin, how do you guys unwind after a stressful day at the office?
Meditation.
Oh.
And I run to the gym, especially a punching bag.
Nice.
Actually.
Caitlin, what do you like to do in your free time to unwind?
go to Las Vegas. Because I like to do gamble because I like to win money.
I also like to actually take care of my nephews. I got 2 young, really rambunctious nephews. And I actually have permission from both my brother and my sister to take them by myself. And how many people with a Down syndrome to actually take care of a kid without a disability? Can you ever thought of that? Of having an uncle or an aunt that has a disability and they take care of their nephew or their niece. It's like showing them when they get older, when they get into the world cliques they are, because there are so many different cliques. They should be the ones not to bully people with disabilities, but they should be the ones to stop the bullying.
I gotta say something. I have respite too. I do IRAs and Catholic Charities because Catholic Charities is someone will help me with some chores and something like I do at home sometimes. But peer mentor or supporters will help me to do tasks at home with me if they need. They told me, oh, let's do this, let's do this, let's do this. And then if you need some help, they ask me, do you want help? I said, yes, please. If you don't help, I can do my own. Like, I'm going to do my independent living skills. Like when Sandra does too. But if I have more support, like 20 hours with support workers with me, and I get more higher chores I do, and then when I do even raising bars way up high here, I can go to, I like to do social stuff outside of my apartment. I like to go to zoo, the Venice Zoo, and also when Joe will to say something for me, because I know Joe weeks with my mom, because my mom helps me with me when she say get up in the morning. It's really hard for me to wake up, but I know that. And when Caroline said the timesheets for Repsit, Respite had timesheets for, they have grids on the timesheets. They will mark on the grid when you have more times to fit in my work schedule, and when you have many times in your future, when you have more building task in my, I'm gonna share my heart, because my mom gives me so many times to wake me up in the morning when she said, my mom is Tori over there, because Rhonda, I know her because I know Jeremy and Keita and Annie.
So we are unfortunately out of time for today, and I want to be respectful of everyone's time, but I can't think of a better way to end it than with our two self-advocates here. And let's give our whole panel a big round of applause. Thank you, everybody.
I just want to